I will invite Dr. Reema to talk on retinal features of systemic autoimmune diseases. Dr. Reema is a professor at PGI Chandigarh. She is a professor of retina and uveitis. Over to you, Reema.
Very good morning to all of you, and thank you, Dr. Gopal, for inviting me to talk in this instruction course. My topic is retinal features in systemic autoimmune diseases. So coming to the systemic autoimmune diseases, as per the NIH, there are between 80 to 150 autoimmune diseases. So what basically happens in them is there is dysregulation of the immune system, leading to activation of immune cells which attack autoantigens. There is circulation of the autoantibodies in blood which get deposited in the vessels or the organs, leading to inflammation, causing thickening of the blood vessels and leading to ultimately occlusion of the arteries. So various other factors also have an additional influence like genetic, infection, endocrine and environmental exposure. Most of the body parts can be affected by the autoimmune diseases. And broadly, the autoimmune diseases are classified as systemic autoimmune diseases or organ-specific autoimmune diseases. In systemic autoimmune diseases, the autoantigens are present all over the body, and the autoimmune reaction is mediated by autoantibodies. In organ-specific autoimmune diseases, the autoantigens are the organ or the tissues or specific cells, and the autoimmune reaction is mediated by T cells as well as the autoantibodies. So I'll be focusing on some of the systemic autoimmune diseases like rheumatoid arthritis, SLE, and so on. So coming to rheumatoid arthritis, we know mainly the involvement is in the form of anterior uveitis or ocular surface diseases, but retinal involvement is quite uncommon. And whatever happens usually occurs in the form of retinal vasculitis. Again, it may be asymptomatic. And that's why this article, I find it very relevant, which says that retinal vasculitis in rheumatic diseases is like an unseen burden because there is more of retinal vasculopathy. There is leak which is detected on fluorescein and patients really may not be symptomatic. There is another report of geographic choroiditis along with retinal vasculitis in rheumatoid arthritis. And there is a comparison of the choroidal thickness in these patients as compared to the healthy controls, where they found thinner choroid because of immune-mediated damage of the choroidal vasculature. Again, there are some anecdotal reports of optic neuritis with or without pachymeningitis in rheumatoid arthritis. The comparison of the choroidal and the retinal layers has been done in rheumatoid arthritis versus the healthy controls. And what has been found is that there is thinning of RNFL and the ganglion cell in rheumatoid arthritis, which suggests there is damage of axons, and the mechanism postulated is the autoantibodies bind to the RGCs, cause autoantibody-mediated tissue injury, leading to apoptosis-related thinning in genetically prone patients. This can impair visual acuity even in the absence of ocular symptoms. Coming to SLE, the prevalence of SLE retinopathy has been found to be 15.8% among newly diagnosed SLE patients. So it's not rare, but it's not very common also. Cotton wool spots are the most vital clue to the presence of an active SLE, and they are seen nearly in 50% of the patients who have ocular involvement. They may or may not be accompanied by retinal hemorrhages and vascular occlusions. And retinal vasculopathy, when present, is significantly associated with neuropsychiatric SLE. The term lupus retinopathy refers to any clinical manifestation of SLE in the visual system. It could be because of the disease itself, or it could be secondary to the renal involvement in SLE, or due to the drug toxicity. Lupus retinopathy has a wide spectrum. It may be in the form of lupus microangiopathy, vascular occlusion, vasculitis, hypertensive retinopathy associated with lupus nephritis, and autoimmune retinopathy. This could be as mild as this. This is one of our patients, known case of SLE, but no symptoms, just came for routine screening, and we found these cotton wool spots. It could be as bad as this, where the patient is symptomatic and you have numerous cotton wool spots which presents like Purshas-like retinopathy, and when you do a fluorescein, it shows marked retinal ischemia in the area of cotton wool spots. So this causes profound vision loss, and Purshas-like retinopathy or PLR in SLE has a lot of significance. There is a study from China where they've screened more than 5,600 patients of SLE just over a period of a decade, of which 8 had PLR. Out of these 8 patients of PLR, 6 had CNS lupus, and this was found to be the higher in patients who had PLR as compared to those who did not have PLR. Now, surprisingly, all these 8 PLR patients had a very high SLE disease activity index, which is 20 or more, and almost always associated with a poor visual acuity recovery. I'll quickly take you through some of our cases of SLE. We saw this woman, 30-year-old woman, in June 2024. She came with right eye sudden loss of vision, no systemic diagnosis. She had no light perception in the right eye, and you can see almost like a Purshas-like retinopathy in the right eye, multiple cotton wool spots. The left eye was 6/9. When we did the fluorescein, it showed marked ischemia. There was macular edema on the OCT along with swelling of the retinal layers. So she was, because there was marked ischemia, we advised a prophylactic pan-retinal photocoagulation, started oral steroids high dose, and also got a rheumatology consult along with the relevant lab tests. Now, in 2 weeks, when her PRP was over in the right eye, she came with left eye, no light perception. Now, you can see the fundus was normal. A quick thought we had, is she malingering? No. We did a fluorescein. You can see delayed arterial filling, specifically in the inferior half. So something was there which we could not see in the fundus, and the late angiogram was perfectly normal. We took a neurology consult because she did give history of headaches and vomitings. So they advised us to, now this time we gave IV methylpred because this time the second eye got involved within a period of 2 weeks. They ordered CE MRI, MR angiogram. They did the CSF analysis. It was found to have a high opening pressure, not really very high, but crossing the borderline. The upper limit is 20. This was 22. So they prescribed acetazolamide and did a therapeutic lumbar puncture on the 4th day. These were simultaneously the investigations that we had got the reports. ESR was high, CRP was high. ANA was 1:160, but the rheumatologists were watching her because the other tests, none of the other tests were positive. Now, 1 week after the therapeutic lumbar puncture, her vision improved in the right eye from no light perception to counting finger close to face, and left eye from no light perception to 6/9. Now, again, this was not malingering because we had the visual fields. The one on the left is when she had no light perception, and within 2 weeks, you can see the reversal of the visual field deficit at 1 week. So we made a diagnosis of bilateral sequential occlusive retinal vasculitis in a case of idiopathic intracranial hypertension. The neurologist called it as IIH, a case without papilledema, and there are reports in literature of IIH without papilledema. But 6 months later, she comes back. Now she comes with these lesions, which we were looking for. Our presumptive diagnosis was SLE, but none of the investigations supported this. So she had this malar rash, lesions on the back, and this time the rheumatologist made a quick diagnosis of SLE. So basically, this was a lupus retinopathy, neuropsychiatric SLE. She was also on antidepressants, and she had a psychiatric consultation done. Optic nerve also has been reported to be involved in SLE. Again, not very common, but there are reports of optic neuritis or AION in SLE. Lupus retinopathy could also be caused secondary to the drugs, which I mean immunosuppressive therapy, because these patients are immunocompromised. So this was again a woman who was a known case of SLE, presented with sudden loss of vision in right eye. I just wanted to show you this retinitis lesion in the fovea, which was captured very well on the OCT as a rain cloud sign. So she was having basically a fungal retinitis because of the immunocompromised state. So this was at the baseline, and this was at 6 weeks when she was treated with antifungals. Autoimmune retinopathy in SLE has also been reported, and it mimics retinitis pigmentosa-like clinical picture even on the ERG. So one has to be very careful in making these diagnoses of AIR in SLE. Systemic sclerosis, again, the disease is not very common. It's very rare. There is excessive production and accumulation of collagen leading to hardening and tightening of skin. Few reports of peripheral arterial occlusion, retinal and choroidal changes occurring because of systemic hypertension. So this is our own experience where we did ocular screening of these patients of systemic sclerosis who were enrolled for all the findings. I'll not mention about the anterior segment findings, but in the fundus we found there was an increased choroidal thickness in almost 30% of the eyes, and only one case had angioid streaks, which has never been reported. This was not a patient of myopia, so probably related to systemic sclerosis. Psoriasis has been linked with VKH. There are few reports of VKH and psoriasis, and their coexistence has been linked to because certain common HLA haplotypes. So again, we had this patient who was a known case of psoriasis, presented with initially right eye optic disc edema as the first manifestation on VKH, and you can see now he developed these bullous retinal detachments in the right eye. OCT shows it very clearly, followed by combined FFA and ICG. You can see the granulomas and the pockets of fluid on fluorescein. Even the left eye, which was asymptomatic, showed subtle granulomas on ICG. And these are some of the systemic associations of VKH where psoriasis is in the list. Celiac disease, again there is an immune reaction to gluten, and there are case reports of CRVO and combined CRO and CRVO in celiac disease. Similarly, in Crohn's disease, retinal vasculitis, and simultaneous arterial and venous obstruction of the retinal vasculature. So to summarize, retinal involvement is rare in systemic autoimmune diseases. It can be asymptomatic, but it can be sight-threatening, and we have to be very careful in making diagnosis and picking up these arterial occlusions. Thank you very much, and thank you, Dr. Gopal, for this opportunity.
Thank you very much, Reema. So there are a lot of systemic vasculitis and autoimmune diseases which have their signature marks in the retina. I would just like to ask you one thing. When we classify vasculitis, we classify into large vessel vasculitis, medium vessel vasculitis, and small vessel vasculitis, apart from the idiopathic or other retinal vasculitis that we know. So would you please shed some light on how to differentiate between the large vessel vasculitis, which is exemplified by the carotid arteritis, versus a medium vessel vasculitis versus small vessel vasculitis based on retinal examination?
Okay, so I think in this context, Takayasu retinopathy would be most appropriate, and I think it will be covered by, I didn't cover it because I thought it would be covered by under cardiac and neurological. So anyway, Takayasu retinopathy may be detected, one, in a known case of Takayasu. Sometimes they're not known cases and the ophthalmologists make a diagnosis of Takayasu. So here you have it's a granulomatous autoimmune inflammation of the large, primarily the aorta, involving the common carotid and then involving the ophthalmic artery. So here you have these hemorrhages, tiny hemorrhages or maybe microaneurysms in the periphery, coupled with findings of low IOP, feeble pulse, or sometimes that's why it's known as a pulseless disease. And clinically, you just see these subtle hemorrhages all over the fundus, and you do an angiogram and you find all the stages of Takayasu retinopathy.
Okay. Okay.
So I'm sure it will be covered in
Thank you.
some
Thank you very much.